A little background before we get started on the tutorial. Please understand that depending on how you orient the mastectomy and depending on the laterality of the specimen, will change the clock face position. We have 4 clock faces here demonstrating the different orientations and the different lateralities. So please take note of that. Here we have a radiograph of a simple mastectomy. So often with these mastectomies and also lumpectomies, you'll find interparenchymal metallic markers. Here we've got 2 markers, one here, one here. We also can see the contour of the tumor here. So just to understand, there's a variety of type of these markers, and these are markers where the person has gone in and had a abnormal mammogram, and they decide to biopsy the site. And when they do that, they often leave these markers behind. So when there's a excision or re-excision, they can make sure they get those areas. Once again, there's a variety of different kinds of markers and types, as noted here. Let's get started on the tutorial. This is a grossing tutorial video on how to process a left simple mastectomy without nodes for tumor. So we're looking at the anterior surface of the left mastectomy. We've got orienting sutures here and here, which are designated as short superior, long lateral. We have a fairly large skin ellipse here with the nipple here, areola here. We've got multiple nevi that are raised and granular, which are consistent with seborrheic keratosis type of lesions. The majority of them are at least a centimeter or greater from the peripheral skin soft tissue margins. However, there's one here that actually looks like it abuts the skin soft tissue margin here, which I'll make sure and sample. Now, as you can also see from the appearance of this breast, there's more breast parenchyma here than there is at the inferior aspect. So if you were not to have any sutures here or here, you could probably still go ahead and orient it, which is based off the amount of breast parenchyma here and the very little down here. Let's turn it over to the posterior aspect. So posteriorly, we've got a nice smooth plane here. There's no areas of skeletal muscle. There's no defects. There's no areas of retraction or induration. So this is the posterior aspect here. And when we talk about margins, you've got, of course, think about the breast parenchymal margin, which, of course, covers all this area that's not surfaced by skin. So you've got all this is margin. This is all margin. Soft tissue margin, you can call it. Also, this is all margin. Now, you also kind of have to think about the skin as a margin too. You know, you got the peripheral skin soft tissue margin here, but like I said, with the skin lesion here, which looks grossly benign, still touches a skin margin. Okay, so I've weighed the specimen, I've measured the specimen, and I've also measured the skin and talked about the nipple and its appearance in the indurated area. We're going to go ahead and move on to the inking portion of the gross tutorial. I just want to point out a few things about the skin surface, things to make sure that you mention in your gross. The nipple here and the areola surrounding the nipple are not ulcerative and they are not retracted or puckered. That's important to pay attention to. And then also immediately adjacent to the areola here, in the region between the lower outer and upper outer quadrants, is a 7-centimeter area of indurated skin and a subjacent, most likely probable mass. So pay attention to those things on the skin surface, not only the nevi, but the appearance of the nipple, the areola, and if there's any skin changes. I think it's important to note. Thank you. We're now going to begin inking the specimen. I usually do this with Q-tips, and I think the majority of the people do it with Q-tips. Looking at the deep aspect, but this often takes a long, long time, especially if you have a large breast. So what I will do sometimes is get a little bit of gauze, and to kind of speed up the process, not that you have to do this, I'll put a little bit of black ink on the actual gauze itself, and makes the inking go a little bit faster, especially if you get something like this for intraoperative diagnosis or intraoperative examination. So I'm just going to go around here and continue inking the deep aspect black. I think most places do this. And you'll notice I'm doing this on top of a chuck, but I've got the smooth, non-absorbent side up, and I'm doing that on purpose. So now what I'm going to do is put a little bit of vinegar on here, throw a paper towel on top, some more vinegar on, okay? And then I'm going to flip the specimen over. So now we're going to ink the anterior aspect now with blue ink, and we do the same type of thing here. Some blue ink here. Okay. So then we're going to put some paper towels around the edges of that as well, and put some more vinegar there. And kind of let this absorb all the vinegar up. Now just let that sit there and marinate for a few minutes, okay? Now that we've inked the specimen, we've saturated it in vinegar, allowed the ink to stick, I go ahead and take the mastectomy and stick it in another chuck and try to dry it off as best I can before we begin sectioning it. So I'm going to take this out. Now, depending on where you work and where you are trained or get trained, some people will section the breast anteriorly. Some will do it posteriorly. The way we do it is posteriorly. Now, before I begin sectioning this, if you recall, I inked the anterior blue, the deep black. I want to put a little bit of red ink over the lateral aspect here, in case I have to go back to it. Okay? And I'm also going to put just a little bit of orange ink at the peripheral skin, soft tissue, or breast margin where that nevus was at. Okay? A little bit of orange ink there. Once again, add a little bit of vinegar. Let it act as a mordant. Okay? Okay, so now that the specimen's fairly dried off, so like I said, we section the specimens posteriorly. So this is left breast. So I'm going to put this face down like this. And what I also like to do, and you can certainly do this as well, is you can put some numbers here for the clock face so you can remember where you're at. There's a 12 there, 6 there. Okay, this is looking at it posteriorly, left breast. You put a 9 o'clock here, okay, 3 o'clock here. And then what I also like to do is like to find the nipple, wherever that may be, which is right here. And I draw a line so I know where the 4 quadrants are at. Okay? So we got left breast, posterior view, 12 o'clock, 6 o'clock, 9 o'clock, 3 o'clock. Nipple's located about right here. And now we're just going to begin sectioning it. So it's always good to make your sections nice and thin from the beginning to end. It makes your life easier and makes it more efficient in the end. Okay, so we're just going to bread loaf this from medial to lateral. Okay. And I kind of do this kind of seesaw kind of a cutting. Everybody has their own technique and way of doing these things. And as you just noticed when I cut through there, a bunch of, I don't know if it's abscess or if it's the consistency of the tumor itself, but a bunch of this mucoid type of material came out, which I was not expecting. So we're going to stick that in there and try to soak up some of that before it gets everywhere. I don't see that very often. Maybe just a bunch of necrosis as well. I'm rinsing between each slice. Once again. Okay. Like I've done for other tumors. It's got a very mucoid, necrotic cut surface. Okay. Continue sectioning. Now, as I go to the lateral aspect, I'm going to end up sectioning and palpating this lateral aspect a lot more at the very end to make sure there's not any lymph nodes here. All right. Let's pause for a second. So now that I've done the bread loafing, I like to go back a second time and make sure I've got cuts all the way through the breast parenchymal side at the periphery, like right here at the periphery. Sometimes when you initially cut this, you don't get all the way down far enough. So what I like to do is go back over and make sure I've got these breast margins cut all the way through. You don't have to cut all the way through the skin, obviously. Okay, but you don't want to miss anything, especially at these edges right here and here. So make sure you get nice cuts all the way through. Just like that. We're kind of in that region of the necrotic mass, which is right here, which kind of correlates with the indurated area I mentioned at the beginning of the tutorial. So I'm going to continue my cuts here, make sure I don't miss anything. Okay. All right, so, and then what we do is we begin at one end of the specimen, and we start actually what I do is I put out the slice like this, initially look at it, and see if I see anything. And if I don't, then I'll begin palpating it. Same things with these additional slices here. And I make sure I go all the way down, make sure I get all the periphery, the deep margin, make sure I don't miss anything. And just continue on through the slices, just like that. So I've sectioned the specimen, I've palpated it, and this is what I found. As I sectioned from the medial to the lateral aspect, looking at the breast from a posterior view, we've got our clock face here, 12 o'clock, 6 o'clock, 9 o'clock, and 3 o'clock here. This is left breast. As I go from medial to lateral, here's the nipple ducts here, okay? And as I went farther and farther along, as you recall, when sectioned through the breast in this area, all this mucoid kind of almost purulent material came out. And what actually is going on here is there's this necrotic mass right in this region right here. It's subjacent to the indurated area of the skin, okay? And so it begins actually about right here, okay? And then it goes this direction for 1, 2, 3, 4 slices, and actually ends about right here. Okay, so we've got this centrally necrotic indurated mass here, and as I was also cutting through and palpating within the mass, actually I'll zoom in. Within the mass was a circular shaped marker, which I expected to find after doing the radiograph of the specimen, which I'll show you here in a little bit. So here's the marker here, okay? I'm going to put that to the side and try not to lose that. But there is a marker associated with this mass, okay? What I also found as I was sectioning is, so the mass ends about right here, okay? Up in this region over here, there's an indurated area which is not contiguous with the mass, and it may either be a satellite tumor nodule or a lymph node. And what I found in that region was another marker, which is right here. So we've got a marker here, marker here. This marker is associated with the mass. This marker is associated with either a tumor satellite nodule or a positive or grossly positive lymph node because it's so indurated. Okay? And then as I palpate at the very end of the case, I'll check for any more additional lymph nodes here. We'll zoom out for a second. Okay, so as far as dimensions and your relationship to margins, I'm obviously going to talk about the mass and its location, okay? It's at the region between the upper outer and lower outer quadrants, okay? I've already done the distance of the tumor to the nipple. I'm going to mention how far or what the closest inked margin is to the tumor, which turns out to be this area right here. This is anterior blue ink, so this is the closest anterior margin here, and this is the closest deep margin here, okay? So I'm going to mention its location, talk about how the mass is subjacent to the area of indurated skin. It's so many centimeters from the nipple. It's so many centimeters from the closest anterior margin here, so many centimeters from the closest deep margin here, okay? And then I'm going to talk about this satellite tumor nodule up here versus lymph node, and it's a distance from the main tumor. And then when I sample, I'm going to make sure I take some intervening tissue between the main mass and the indurated lymph node versus satellite tumor nodule to make sure that this histologically is not just part of this main mass, if that makes sense. Okay? And as far as this nodule goes, I'm going to talk about it being up in this quadrant and talk about its relationship to the margins and how close, what's the closest margin that this nodule is closest to. And then last, I'm going to, once again, which is very important, I see this often, this doesn't happen. I go back to a case, make sure, even if you have a simple mastectomy without nodes on the requisition, make sure you palpate and section for nodes in this area because you can still find one. And like I said, this is questionable whether this is a lymph node or not anyways, okay? And feel free to map out the specimen in front of you while you're working on it so you know where you're at and you can kind of keep things straight. Last but not least, what I'm going to do is I'm going to take representative tissue from each quadrant, fiber tissue from each quadrant, and then take a section of the nipple here. And I'll go over those sections with you in a second. I just want to briefly go over the radiograph for this specimen. As I mentioned before, there's a metallic marker here, metallic marker here. This was the metallic marker associated with necrotic mass, and this was the marker associated with the indurated lymph node versus a satellite tumor nodule. So I just want to make a point of these two markers right here. In summary, if you look at this annotated diagram, I took a section from the nipple, I took a section from the closest anterior margin to tumor, the closest deep margin to tumor. I took approximately 1 section per centimeter of tumor sequentially. I made sure that I included the area of the marker. I also made sure I included the area of the indurated skin superficial to the mass. I then took a section over here of the intervening tissue between the mass here and the indurated lymph node versus satellite tumor nodule. And what I'm not showing here is I also took sections from fibrous tissue from each quadrant, from the upper outer, lower inner, upper inner quadrants away from the tumor. So that's real important to do as well. Thank you for watching. Hope it helps.